Welcome back, audience. Welcome back, Dr. Strulak. Next panel is dedicated for the much more for the diagnosis purpose, for the pain management and the pain treatment after the diagnosis, than for the particular procedures. That's Przemek, stage is yours. Please introduce your case to the audience. Thank you.
Worker. He sits about 9 to 12 hours in front of a computer, and he has, I call this the administrative sickness. He has on both legs, he has dysesthesias, which are caused by the peroneus communis, which is being through the way he's sitting, it got damaged. We have made a electroencephalographic procedure before with the neurologist, and both peroneus superficialis are slower in as they should, and he has on both legs he has tingling and burning pain. Why am I bringing this procedure? Because it's actually a procedure where I decide what I'm going to do later. The first thing I do, I look at the patient, I make an ultrasound of the foot, of the leg, and then I find the peroneus superficialis between the two muscle compartments, the medial and the lateral muscle compartment, and I have a look at it. And actually, in this patient, the nerve has fibrotic changes around it because it was compressed for a very long time through the sitting position. What I am doing is actually a hydrodissection. So my first step is to find out if we're on the it's a block which I make to find out if I'm going to treat the right thing. So I put a local anesthetic and I make a hydrodissection. You see that the hydrodissection on the monitor. You see the 5% glucose which I'm putting around the nerve. And I am doing that to see if the patient will react to this good. Sometimes it happens that the patient doesn't have any clinical changes after this procedure, and we don't have to do further procedures afterward. But if after this procedures the tingling stays, I usually make a pulse radio frequency. If the patient comes back to the tingling and to the burning pain, I make a cryo. What I mean to say with that is that the tingling is actually a sign of compression of the nerve, but it's not a sign of a neuropathic pain. If the neuropathic pain comes back, the indication is actually for cryo. So what I wanted to show you with this procedure, guys, is that actually the patient, the methods we're using are combinable. We can use both methods, and we can achieve a very good outcome for the patient, and the treatment brings a patient actually in a situation which all the methods are used to heal him. There is no competition between the methods. You just have to find the right place to put them in. So now again, to what you're seeing on the picture, this is the hydrodissection which I am doing. The nerve is being shown transverse from dorsal to ventral. Underneath you have the fibula, which which lies under on the left side of the screen. And in between, you see the two compartments of the muscles, and just in between them, the peroneus superficialis, which causes the pain. The patient was, after this procedure, pain-free. He has a follow-up in 5 days, and we're going to see if he has any clinical signs for the next treatment, or maybe we don't have to do anything. So again, we are doing a procedure which tells us the way and which gives us the possibility of both options. The only option we cannot use here is an RF, because it's actually it would be counterproductive, because the outcome would be that we would destroy the nerve, and probably in the end we would have to use again a cryo to treat this nerve afterwards. So in this case, the PRF, the pulse radio frequency, and the cryo are the methods of the choice in treating this patient. You're going to have a look right now. You can see the hydrodissection with the glucose. I'm sorry that you don't see it very well, but you see a really big bubble, black bubble, which is forming between the two muscle compartments. And at the end, I will show you the nerve, how it looked after the treatment. And this would be actually my case. Would you have any questions, Edmund?
Thank you, Przemek. It's a nice case, and this case presenting such situations when the last panel we talk about that choosing the proper method, cryo or highest low temperatures, or cryo or highest temperatures. But generally, we have to remember always in front of the decisions, it is the proper interview with the patients, proper diagnosis, and diagnostic block as well. Sometimes 2 times I heard it's needed to be sure what is the indications, and then you can properly choose the one of the interventional method, what is the side of the portfolio of your clinics or any other clinics. That's
Okay,
my
in the case. Mhm. In
yes,
the
please,
case
please
of
go
this
ahead.
patient, he will he will have a follow-up in 3 days, and we will see if he has any clinical signs. If he has, if he keeps is painless, then we're not doing anything. We make a second follow-up in about 2 weeks. If he gets again the same pain, we make a second procedure where we do the hydrodissection.
Okay.
If the outcome would be like that, if he comes back and says he has exactly the same pain as before, pain, I'm not talking about tingling, I'm talking about pain, then we do a cryo.
Okay.
Mhm.
Thank you. That's take-home message
Welcome.
from previous presentations and your case studies, presenting the situations that all those doctors who want to effectively treat pain problems, they have to get the large as possible portfolio for the procedures, including cryoneurolysis devices and thermoablations devices as well, peripheral stimulators, and regenerative medicines tools as well. It's in
Mhm.
that's my conclusions for sessions for both panels. I have because we have a little bit, if you don't mind, we have a little bit more time.
Yes. But
I
I missed the
agree.
pictures at the end.
Yeah, you can present these pictures because they are so important to see what we are talking about, that hydrodissections.
So the picture you actually see is on the left side you have the medial compartment, on the right side you have the lateral compartment, and on the top of it you have the nerve. This is the nerve after the dissection. You see the fluid around it. It's lifted from the bottom. It's just on the top of these two muscle groups. And this is also the cause why the patient had such a problem, because the nerve is very subcutaneously, and probably through keeping his legs under the stool, under the chair, and pressing against his legs, he caused the entrapment of the of this superficial peroneal nerve. So that's what we do at first. We repeat it again, and if it doesn't really help, then we do a cryoablation. Here again, you see the needle under the nerve, and afterwards the nerve, which is lifted up and with the fluid all around it, in between the fascias in which the nerve was actually trapped.
Okay,
That's it.
thank you, Przemek, for that. Because we have around the 10 minutes, and if you agree, we can continue some questions
Yes.
to specialists who is familiar for the both techniques and both approaches. That's I have a questions like this: what are technical and anatomical limitations for those two approaches? Have you
Okay.
seen that?
So yes, of course. The anatomical. I'll start with the anatomical. You can't use an RF for nerves which are mixed, motoric and sensoric. That's actually a no-go. You can use cryo because, to tell you the truth, you don't have to be scared that even if the patient has uh, um, a small motoric dysfunction afterwards, it always comes back. But you get a very good pain relief through this procedure. That would be the anatomical. The second thing is using both methods very subcutaneously. If you use an RF, you actually always burn the skin. It's there's no possibility of preventing this to happen. If you use cryo, you can just shorten the treating times. You see actually the ice ball which forms around the needle under the ultrasound, so you actually know the moment you have to stop so that you don't get a frostbite. So actually, the method is more controllable. If you put in the same place an RF needle, you don't see the area you're treating. You only see the tissue which is changing and deforming, but you do not see if the skin is being heated up to. Of course, you can put your hand on it and look if it gets hot. But if you treat it this way, it's mostly too late to do anything if you do an RF. If you do a cryo, you have a very big margin for this treatment. Then the ultrasound has opened the doors for the cryoablation. You can use it actually anywhere you want, as long as you see it. The problem starts with the direct indications for RF, where you have medial branches of the vertebra, and you have a patient who's like 120 kilo. And here, if Igor said only ultrasound, I would say the better method you have in the hand. In this case, I would probably use a C-arm, or I would choose a CT because then I know where the needle is. Okay, so
Yeah, that's another one point of the discussions. Is the proper guidelines for the procedures, always connecting with the tools what you get in the OR or
yes,
ambulatory, and your skills. Because we are over the time, Przemek, I would like to thank you so much for your time and for your all
welcome.
kind of explanations. Thank you so much for
Okay.
the sessions. Thank you so much once again, Igor. I'm sure he's listening us. Thank you so much for the panel.
Thank you very much for inviting me.